very much. It's a quick event, and everybody should come to San Francisco in November, so we can get to know each other. There are many good speakers. So this is okay. So essentially, we want to define anatomical ACL reconstruction as a functional restoration of the ACL to its native dimension, collagen orientation, and insertion site. And as surgeons, we can control the insertion site. I think the revision idea is the same. Try to get the ACL back to the right position. Essentially, there's a good, Vimedi video on this, on the flow chart. I think everybody should take a look at it. Now, it's very simple nowadays you can tell quickly whether the ACL is in the right position. This is a paper, AJSM, last year. So this patient has an 8-degree measurement, which is very anatomical, very vertical graft. We say that anything, less than 30 degrees is probably non-anatomical. So just measure on the AP, X-ray, you can see right away. Now, if you have the MI on the other side of this patient, is even better. So on the left side is a normal MI on him. On the right side is the ACL graft, and you can see there's about 30-degree difference on the inclination angle, which I think everybody should measure that. This is a good exercise to do. And if you look at the CAT scan, which we use in all revision cases, this is a very high, femoral tunnel. The tibial tunnel is a typical so-called PL in the very posterior part of this kind of technique being used. So essentially, we redrew the tunnel, like Darren showed you, and we also anteriorized the tibial tunnel. And now this measurement is 49 degrees, and we measure, all this, numbers. This is very close to each other, inclination angle, and essentially the length and the sizes are also similar. So this is a good exercise to tell us that we did the ACL in the right anatomy. And I think we should do it, in every case that you have done yourself, so you can keep yourself honest. Now, Frank Noyes wrote a very good paper recently and say that most of his revision cases are because of wrong anatomy. And I agree with you, with him, that may be anatomical factors. But however, there are many non-anatomical grafts that survive. In fact, I probably have done thousands of those in the wrong position, and they survive. This is a good example. This is a lady that I did when she was teenage, a very vertical graft. But you can see the graft is healed well in the wrong position, measurement 10 degrees. And the examination office is very stable. But if you took him to the OR, it's not that stable. So it's always misleading in the office. Scope essentially showed that arthritic changes, and the CAT scan show a wrong position PL to high AM. So, and in fact, I re-examined her in the office 6 months later, still very stable. So this is really a little unstable knee, but the patient is not very active, and this is why, she can get away with it. Now, if you do ACL, even in a professional athletes, it can potentially, they can potentially play sport with a wrong tunnel. This is an NFL player I did, almost 20 plus years ago. Let's go back. This is a wrong, tunnel, definitely a high AM PL, just like we did as an allograft, played 11 years in NFL, and you can see, the arthritic changes. So this patient, essentially, if you did the ACL in the wrong position, there are less force in the ACL, actually, and more force will go between the condyle. And this is one reason why these people may get wear and tear, besides meniscectomy and condyle injury. So why do this non-anatomical grafts survive? And it's all based on anatomy. So this, notch height, which is a new concept nobody talk about. So if the notch height is high, you can see on the 25 millimeters, any graft almost can survive. If the notch height is low, like 10, 11 millimeters, many grafts cannot survive, many. Okay, so this is a case. On the left side is a 10 BTB, failed 2 times, done by very good surgeons. And because the notch is only 11 millimeters high. So the graft in this case should be either very, oval shape, maybe hamstring type, 5 or 6 millimeters over the top. Now, on the right side is also a wrong tunnel. In fact, the right side is better tunnel. The right side, but the notch is 25 millimeters. The graft survive, and the patient will essentially can play sport and everything and stable. And but with time, this patient may have potentially wear and tear problem. So the other problem with a wrong tunnel is something called capture knee. I just saw this patient recently. I have ACL done. You can see measurement is quite a little bit vertical, but he lacked 10 degrees of full extension and really miserable. He cannot do anything. And the examination in the office and the OR are both stable. I cannot tell. There's no shifting. The Lachman, everything, the KT is normal. But this is the graph, how it looks like. 70 degree, very vertical. And if you do the CAT scan, you can see both the femoral side and the tibial side are absolutely in the wrong position. So if the tibial side is quite right, sometimes you can get away, with non-capture knee. But this patient is absolutely miserable. And essentially, we redo the knee, as you can see the new measurement. And in fact, this patient, on the first visit, 5 days post-op, he already said, hey, my knee is much, much better. I can extend completely, and I feel, I can move, really easily. Just only 5 days post-op. Now, I think that beside revision surgery, we have also looked at mid and long term. We have to eliminate non-anatomical ACL reconstruction as a risk factor for osteoarthritis. So we can do ACL in the wrong position. People can play sport. It doesn't mean in the long term it's good for these people. Now, what do we tell patients? We tell patients that you'll be back in 6 months, and you'll be 95% success rate. And I really want to challenge this concept. Okay, the criteria to return to sport is look at range of motion, strength, but never talk on graft healing. So essentially, in 6 months, go back to sport. You can look at the graft, really high intensity, not mature graft at all. I think if you let this patient go back to play, it's going to be a problem. And you can see this kind of a patient, they want to go back right away because they feel they're good. This patient is 5 months post-op. And he showed me the tape. He said, Dr. Fu, why don't you let me play? Because I can play, you can see. I have a brace, and I can do anything I want. And I think if you do ACL anatomically, many of these people can do this, okay? But the only problem is the graft on the MRI is really, intensity is really, high. And so it ruptured, quickly. And you can see time 0, 6 months, 24 months. It takes time, okay? So in our practice, if you want to go back in 6 months, we do MRI. Autograft, 9 months, allograft, 12 months in younger people. If you're older folks, it doesn't matter because you're not as active and you may not be as critical, okay? So you don't have to do that. Now, how do you look at success? If you look at such revision rate, is not the way to do it because if you look at how people play, many people can play without ACL. But if you want to look at it more objectively with 3D, MRI, CAT scan, biomarkers, things like that, you will find much more failure than you think. So definition of failure, rupture, range of motion, instability, pain miserable. So these are the triangle we talked about years ago, technique, biological trauma, and this patient show it. The graft seems to be there, but it's high intensity, it's immature at about 1 year. If you look at the CAT scan, it's the wrong position, PL to high AM. And basically, it's the wrong position, and so the wrong position will affect the graft healing too, in some cases. So in conclusion, we need to be anatomical, we need to be individualized every patient, we have to understand healing, and we have to be critical on our outcome measurement. Thank you very much.
Thanks, Freddie. Excellent talk as usual. I'd just like to throw a question out there for our panelists. So Freddie, you talked about the inclination angle. And I think that's based on something that you published recently. And I just want to ask our other panelists if they're familiar with that and what significance, if any, does that play in your decision making? So,
that's too fancy for me.
Okay.
As we get better at learning about this and more individualized surgery, I think Pittsburgh's group is helping us learn about this stuff. But for now, I just try to put it center on both sides.
John?
Yeah, I agree with you.
Okay. And Steve?
Well, I think, Freddie, you showed that notch height. That's really the variability in the roof angle that you're showing. Those two sagittal images, I think one was 10 and one was 20, I think, for the height of the notch. Those are really parallel to the two X-rays that I showed with the forgiving and unforgiving knee, and that is that roof angle, or the height of the notch, whichever way you want to look at it, varies from patient to patient. And I think you showed that the patient with a high notch had a graft that worked pretty well, and the one with a low notch didn't, and I would submit that that's due to roof impingement. And also, the MRI signal change that you showed is pathognomonic for roof impingement. I mean, when the graft is placed without roof impingement, the signal in the graft never changes its intensity from the day of surgery till 2 years. And we showed that with serial MRI in a variety of grafts, hamstring autograft, BTB autograft. It's all published in JBJS, a sports journal, and arthroscopy. And so when you see that signal increase, I agree that the graft is weak, but I would suggest that that problem is caused by the surgeon, not because of the collagen or the healing in the graft. And Andreas Weiler showed us that in the animal model, that when the signal intensity is low, and he showed that in some sheep, he had their goats he used. Some of the goats had low signal, some didn't, and the ones with the low MRI signal on MRI had the high strength in the graft, and the ones that had the high signal had the low strength due to more water content, edema from the repeated injury as the knees extended. So I think that's the problem you get into when that tunnel sneaks anterior in the tibial side, that graft hits the roof, and you'll see that regionalized signal increase within the notch. It's not in the tunnels, and it's pathognomonic for roof impingement. There is no other cause for that. It's not a remodeling phenomenon. It's an impingement problem.
I think we're going to move on. I'm going to go ahead and give the last talk, and then we're going to come back to that. And Freddie, I'm going to ask you to comment on that momentarily, okay?
Okay, thank you.